Good afternoon, students. Today's our topic is condition accompanied by loss of consciousness, syncope. Now we're talking about syncope. Syncope is defined as a disease loss of consciousness due to cerebral hypoperfusion, characterized by sudden onset, short duration, and spontaneous full recovery. Similar clinical manifestations are characteristic both for syncope and for other pathological conditions, which necessitates a differential diagnosis with other disorders. This group of state is called transient loss of consciousness. And now we're talking about these conditions. Transient loss of consciousness, TLC, is defined as a state of true or apparent loss of consciousness, accompanied by loss of perception characterized by amnesia during a period of unconsciousness, impaired control of motor function, loss of reactivity, and short duration. There are two main groups of TLC: TLC to traumatic brain injury and non traumatic TLC. And this classification of transient loss of consciousness, non-traumatic and traumatic. It can then divide into syncope, epileptic seizures, pathogenesis loss of consciousness, rare causes. For syncope, it can be divided in reflex syncope, orthostatic hypotension, cardiac causes. Epileptic seizures can be divided in general seizures, tonic-clonic, atonic-tonic-clonic. Pathogenesis transient loss of consciousness. It can be zygomatic pseudosyncope, syngenic non-epileptic seizures, and rare causes: transient ischemic attack, subarachnoidal hemorrhage, subclavian steal syndrome. TLC group. This definition of the TLC group is based on pathophysiological features. The diagnostic criteria for syncopes is cerebral hypoperfusion. For an epileptic seizure, abnormal brain activity. For physiogenic CLT, a physiological conversion. Classification of syncope. Now talking about reflex syncope. Reflex syncopes can be divided into vasovagal situation, carotid sinus syndrome, and not classification form. Vasovagal. Orthostatic vasovagal syncope is a standing position, less often in a sitting position, emotional stress, fear, pain, somatic or visceral, performance, instrumental, environment, fear of blood. Situation during urination, stimulation of the gastrointestinal tract, slow and identification, cough, sneezing, post-load, other, for example, laughing, playing with instruments, carotid sinus syndrome, and non-specific forms without prodrome and without triggers or typical manifestation. Next up, syncope due to orthostatic hypertension. It must be remembered that hypertension can increase with fluid retention in the venous system during physical activity, stress, after eating, postprandial hypertension, or after a long stay in a lying position, the training patients. Drug-induced orthostatic hypertension, most common cause of this reason of syncope. For example, when taking vasodilators, diuretics, phenothiazides, or antidepressant group drugs. Decrease in circulation blood volume. It's specific for bleeding, diarrhea, vomiting, etc. Primary autonomic dysfunction is neurogenic reason of orthostatic hypertension. Idiopathic autonomic dysfunction. Multiple system atrophy, Parkinson's disease, dementia with Lewy bodies. Secondary autonomic dysfunction. Diabetes mellitus, amyloidosis, spinal cord injuries, autoimmune autonomic neuropathy, paraneoplastic autonomic neuropathy, renal failure. Next reason of syncope is cardiac symptoms. Rhythm disturbances are the primary causes. It can be bradycardia, tachyarrhythmia, structural heart disease, and cardiopulmonary pathology. Bradycardia. It can be sinus node dysfunction, including tachybrady syndrome, atrioventricular condition disorder. For tachyarrhythmias, it can be supraventricular or ventricular, structural heart disease, aortic stenosis, acute myocardial infarction, myocardial ischemia, hypertrophic cardiomyopathy, Intracardial neoplasm, it can be a cardiac myxoma, other tumors. Pericarditis, this is cardiac tamponade, congenital anomalous of the coronary arteries, prostate heart valve dysfunction, and cardiopulmonary pathology and vascular pathology. Thromboembolism of the pulmonary artery and its branches, acute aortic dissection, pulmonary hypertension. Clinical signs that allow a diagnosis to be made based on an initial examination. For reflex syncope, is specific. Long history of recurrent syncope, particularly in individuals younger than age of 40. Occurrence after an unpleasant usual image, sound, smell of pain, associated with prolonged standing, relationship with both food intake, connection with being in a crowded place or with high ambient temperature, sign of an activation of the autonomic nervous system before development syncope, pillar, sweating, or nausea or vomiting. Relationship with the heart rotation of carotid sinus pressure, as with tumors, while even when narrow collapse, absent of cardiovascular pathology. Syncope due to orthostatic hypotension. Duration or after standing, prolonged standing, staying in a standing position after exertion, postprandial hypertension, temporal associated with inhalation or change in dosage of medication with vasodepressor effect or diuretic then promote the development of hypertension, present of autonomic neuropathy or Parkinsonism. Cardiac syncope. It's specific during stress or while lying down. Sudden occurrence of interruption of the work of the heart followed by syncope develops. Family history of explained sudden cardiac death in young age. Presence of structure changes in the heart or coronary heart disease. ACG changes indicated the possibility of arrhythmic syncope, double band block, morbid 2-degree AV block and 1st-degree AV block with significant prolongation of the PQ interval. Asymptomatic severe sinus bradycardia 40-50 beats per minute or atrial fibrillation 40-50 beats per minute, prolonged or shortened QT interval, and others. For diagnostic measures, of course, it's first we should ask patients in primary examination, anamnesis collection, and general examination, including blood pressure, measured 3 minutes after transmission to a vertical position. This is orthostasis. Registration of a standing 12-lead ACG blood test that can for us to check electrolytes, hemoglobin, troponin, B-type, natrium peptide, glucose, D-dimer, hemostatic system analysis, blood oxygen saturation. Provocation tests such as massage of carotid sinus and tilt test. Monitoring. Extended loop recorder, extended loop recorder, ambulatory ECG monitoring for 7 days, 24-48 hours, blood pressure monitoring. Other diagnostic measures test to assess the function of the autonomic nervous system. We can check orthostatic test, Valsalva test, deep breathing test, cold pressor test. For cardiac examination, this organization of access to echocardiography, stress test, electrophysiological studies, coronary angiography. Neurological examination. Organization of access for neurological examination, CT computed tomography, magnetic resonance imaging, electroencephalography, video electroencephalography. Physiological and psychiatric examination. Logical psychiatric examination with it to assess for logical consultant and psychiatric concession for mental disorder or psychogenetic syncope. Implantable ECG recorder. In a case of syncope with long break in between attacks, event-based ECG monitoring is more informative. The event-based monitoring technique involves implanting a portable monitor under the skin of the anterior chest and then activation in the recorder. In modern monitors, the portable battery change is desired for 3 years of conditioned operation. The ECG is automatically detected at long duration asystole, bradycardia, paroxysm of atrial fibrillation, and ventricular tachycardia. And now talking about differential diagnosis of syncope in transient loss of consciousness syndrome. It can be Margani-Adams-Stock syndrome, sudden loss of consciousness, hemodynamic disturbance due to arrhythmic events or condition disturbance, hyperglycemic ketoacidotic coma, sudden loss of consciousness, hemodynamic disorders, pallor, hyperemia, moisture, dryness of the skin. It's according to type of the condition, the smell of acetone and the bad air. Hair and neck injuries, sudden loss of consciousness, hemodynamic disorder, presence of bodily injury, fracture, signs of subnodal hematoma, anisocoria, soft tissue of heart damage, stroke, sudden loss of consciousness, focal neurological symptoms, hemodynamic disorder, epileptic seizures, sudden loss of consciousness, convulsive syndrome, hemodynamic disorders. Drastic ischemic attack in the vertebral-basilar region, sudden loss of consciousness, opera syncope, nausea, vomiting, dizziness, hemodynamic disorder. And now we're talking about Stock syndrome. It's a periodical fainting spell in which the assisted complete heart block or the high-grade arrhythmia that result in loss of spontaneous circulation and inadequate blood flow in the brain. Named of two Irish physicians, Robert Adams and William Stroke, introduced by abrupt disease in the cardiac output and loss of consciousness due to ischemic arrhythmia. For example, bradyarrhythmia due to complete heart block. What is the causes? Heart block may result from myocardial infarction, fibrosis, anterventricular nodal disease, structural valvular heart disease, myocarditis, electoral disturbance, drugs, rheumatic disease includes ankylosing spondylitis, reactive arthritis, rheumatoid arthritis, scleroderma. Infiltrative processes including amyloidosis, sarcoidosis, cardiac tumors, Hodgkin disease, and multiple myeloma. Symptoms of Margani-Stock syndrome. First, attack line development loss of consciousness, sometimes with epileptic seizures, may be also many-weekend form, extremely short-term disorder like absence. Seizures are often produced by aura-like state, filling up well, pressure on the chest, dizziness. During attacks, the prolonged bradycardia, loss of pulse, decrease of blood pressure, failure develops. Bradycardia may also occur in the internal period. ECG. During attack, lateral fibrillation of the ventricles or asystole, then particular or complete ventricular blockade. It's divided into two big forms. Bradyarrhythmic is the first form. It can be due to atrioventricular blockade, syndrome or weakness of the sinoatrial node. The severity of this syndrome depends on two sensation. Duration is asystolia, with duration of 5 or 5.5 with clear symptoms maybe not be present. If it's from 5 to 9 seconds, dizziness, darkening the eyes, it's more than 10, is loss of consciousness. The state of cerebral circulation. Each patient has its own individual technique for the onset of the attack. Tachyarrhythmic form. Constantly high heart rate, more than 200 per minute or more, especially with reduced myocardial contraction function. High heart rate often occurs in the presence of extracellular pathways with a short effective refractory period, with the development of fibrillation, atrial flutter, or epicardial AV tachycardia. In this case, Ward-Parkinson-White syndrome, atrial fibrillation, atrial flutter, tachycardia, ventriculation, or long QT syndrome. According to treatment of the Margani-Stock syndrome, for bradyarrhythmic form, it's temporary endocardial on transthecal external pacemaker. According to the clinical protocol asystole, you should provide epinephrine. After regarding consciousness, withdrawal of drugs that prolong PQ and slow heart rate, PQ such as beta blockers and metronidazole, verapamil, and zoltazol. And surgical treatment, pacemaker implantation is indicated for tachyarrhythmic form. relief of tachycardia paroxysm by electrical pulse therapy, surgical treatment. With long QT interval syndrome, complicated by ventricular tachycardia of the period type, intravenous administration of magnesium preparation with Parkinson-White syndrome, ablation of additional pathways, with atrial fibrillation and flood ablations is bundled with implantation of the pacemaker, with ventricular tachycardia implantation of cardioverter defibrillator. When talking about treatment of syncope, all patients with reflex syncope or hypertension should be given explanation regarding diagnosis, provide support, explains the risk associated with relapses, given recommendation on tactics to avoid triggers in provoking situations. These techniques are the cornerstone of treatment for this patient have a major impact on reducing the recurrence rate of syncope. In a patient with severe form of reflex syncope, one or more additional specific treatment modalities should be selected from the following list depending on the clinical characteristics of the patients. Midodrine or fludrocortisone, it's a group of glucocorticosteroids in young patients with a low blood pressure phenotype. Constant pressure maneuver, including training, is necessary in young patients with prodrome. Chance of reduce the volume and antihypertensive therapy with a target systolic BP of 140 in elderly patients with arterial hypertension. Implantation of a pacemaker in elderly patients with predominant cardiac inhibitory syncope, so all according to type and condition of a patient. The patient condition has developed as a result of trauma or not. If so, then assistant perfusion according to protocol for assisting patient with cranial cerebral trauma. If it was no injury, the Glasgow scale of consciousness is assessed. The presence of pulse is determination is the absence of it. Cardiopulmonary resuscitation measures are carried out. If the pulse is safe, then the following actions are performed. Care as with paresthesia, adduction, oximetry, at ventriculation with aggregate breathing through the laryngeal mask, intubation tube, glucometry, ECG, control of the vein with sodium chloride, intravenously, measurement of blood pressure. When measuring in the glucose level is lowered, you should provide 26 ml of 40% glucose solution in glucose injection intravenously. If it is increased, help to write according to algorithm for assistant with diabetic coma. The presence of rhythmic disturbance determines the presence of arrhythmia. Measures are performed according to the algorithm of arrhythmia treatment. Possibility of poisoning with opiates is determined. Naloxone is administered 1-2 ml of solution intravenously, and measures are taken to provide assistance in accordance with algorithm for assisting poison with unknown poison. With the including of poison and the presence of focal or meningeal symptoms, assistance provided according to algorithm of assistance with stroke. In the absence of focal or meningeal symptoms, the possibility of hypovolemia, hypovolemia is determined assistance in provided according to the aid algorithm of this stage. Delivery patient to the hospital bypassing the admission department. And this is algorithm patient with pattern or syncope. If consciousness recovered is yes, you can consider elevation, consciousness of this scale of Glasgow, blood pressure, heart rate, respiratory rate, ECG, check neurological examination, glucometry. Is no coma of unknown region and treat as like common and unknown region. If it's we find signs of hyperglycemia, yes, provide 40% glucose intravenously, and consciousness recovered, delivered to the hospital. It's no, it can be disturbance of rhythm. Yes, if it is no, it can be stroke. It's not delivered to the hospital. Is you can see the disturbance of the rhythm, you should damage up of the rhythm or ventricular fibrillation, ventricular tachycardia with acute heart failure, ventricular extrasystole. Of course, it's malignant bradyarrhythmic forms. It can be sinus bradycardia, AV block second, and third degree AV block, complete sinus with weakness syndrome, paroxysmal tachycardia within neural complex. Yes, let's deliver it to the hospital. So thank you for attention. See you in our classes. Good luck.